Good morning. It's fantastic, A, to be in New Zealand, and B, to see so many people here. So the concept of this course seems to have gone down really well, so we're very excited to be here and to be running it. Really today, what we want by the end of the day is that you guys leave fairly confident in all of the techniques we're discussing with you today. So it's your day, get out of it what you want, ask us questions, stop us in the practical labs, just if there's something you need to be shown you're not sure about. We don't really want you leaving here with many questions today, so it's up to you. You can learn as much as you like. We're going to start looking a little bit of overview of pain physiology, basically, as the first lecture. So where does local anaesthesia fit into the general scheme of pain management? So we'll look a bit about acute pain management, we'll look at some physiology and some pathophysiology. We'll probably be talking about a lot of the drugs that you actually use on a day-to-day basis, and maybe either confirming what you're using already or giving you new ideas about using the drugs that you're already using. Because we already have a lot of drugs in our armoury, and there are little tweaks that we can do here or there just to optimise the use of those drugs. And I think a lot of that will come through today. And a little bit more background to certain cases. The reference here is actually included in your notes. That's a review that I wrote in 2012, and at that point that the review was published, it was published in June 2012, and I think the final revision I did was January. So as of January 2012, that is a pretty bang up-to-date reference. Not too much has changed since. So as far as acute pain management goes, that's the most up-to-date thing there is. If you're interested in chronic pain, actually, that article was paired. I didn't write it, it was some colleagues. It was paired and commissioned together with a chronic pain review, and that's also in the Journal of Small Animal Practice. I think it was published this January, so I always get a lot of questions about chronic pain. It's one of my areas of interest, so that's a pretty good up-to-date review. So back to absolute basics, pain physiology. We're talking about 4 processes, so transduction, transmission, modulation and perception. And we have a noxious stimulus here in the periphery. That signal is coded by the nociceptors, and then the signal is transmitted up the primary afferent neuron to this area called the dorsal horn in the spinal cord, which is our first area of synapse. And there, obviously, you have interneurons, so you can either have an inhibitory or facilitatory effect from your interneurons. It may mean that the patient pulls their paw away. If you step on the cat's paw or something, as I commonly do when a cat's run in front of me down the stairs at home, then they pull their paw away and they vocalise. So that's part of that reflex loop. And obviously, in the conscious patient, there's perception there. The cat reacts to that painful stimulus. What we have to remember is under anaesthesia, we're dulling perception with all of the drugs we're using, so we can't appreciate perception of pain. And actually, from a more technical physiological point of view, under anaesthesia, we talk about nociception rather than pain. So if I refer to nociception, that's what I mean when we're talking about our anaesthetised patients. And we should always remember, just because they're anaesthetised and this system is dulled, all of these systems can be going absolutely wild. So we can anaesthetise a patient with, let's say, acepromazine, an induction agent, and isoflurane. There's no analgesia there at all. We could inflict quite a painful surgery on that patient, and because they're really deep under the anaesthetic, they don't perceive anything. But we're not doing anything in controlling any part of this system here. So this is where we need to think, where can we intervene all the way along these steps to provide excellent multimodal analgesia? This slide is blank quite deliberately, because what is pain? How do we define pain? Does pain mean the same thing to you? Does it mean the same thing to me? No, it doesn't. This is because our response to pain is dependent on our previous experiences of pain. And that's because the central nervous system is pretty clever. You have this thing called plasticity. So your future response to pain is based on your past experience to pain. Other thing I always think about is, what's the difference between discomfort and pain? That's kind of quite a subtlety, isn't it? And some people, whereas I might think, oh, something is uncomfortable, someone might go, oh no, that's the worst possible pain I've ever experienced. So I think really the important thing to remember is pain is always subjective. And these are the typical kind of things that if you read patient descriptors of pain, these are the kind of things that people will use to describe their pain. If we want to look at definitions, the International Association for the Study of Pain has this definition, which is the most worldwide accepted definition. So an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And the IASP are a global organisation, and their website is certainly worth a look as well. If you just Google iasp.org, you'll find their website. Now, of course, we need to think about our veterinary patients here because they can't communicate, obviously, like human patients can. And much of this came about with assessing pain in human neonates. So this is an addendum that the IASP added to the definition. The ability to communicate verbally does not negate the possibility that an individual is experiencing pain and is in need of appropriate pain relieving treatment. So this fits really nicely with our veterinary patients, and we've moved a very long way from the days when people thought animals didn't experience pain. So who do we think is best to judge pain? Is it the owner? Is it the vet? Obviously depends on the situation, doesn't it? So in the acute situation, it's really down to us. The owner's not there. But we rely very heavily on owners for assessment of pain in the chronic pain patient. And I think one of the things that's really important is what is the animal's normal behaviour like. So if you put that dog in a kennel and close the door, does it bark? Will it just howl the whole time? Even if it doesn't before surgery. So that's something really important to take into account with pain scoring is what's the animal's normal behaviour actually like? What does this animal do in that situation? Particularly important for cats. You put a cat in a kennel in the cattery and they'll just sit there and they'll freeze because they have that's part of their fight or flight behaviour. So cats, remember, are very different to dogs. Do we feel well trained in pain assessment? I think we probably are quite well trained, we just need to think about it. We have a lot of experience of dealing with patients that are painful. Emotion certainly comes into it. There's a huge emotional component to human pain, and particularly chronic pain, but we can't really get that from animals necessarily. I think some people, if they really know their dog, they go, yeah, he was really down when he had his after he had his surgery. So I think in dogs there can be an emotional component. Cats, really difficult to assess that emotional component. Can cats be emotional? I don't know. This cat's got an attitude, but I don't know if he's emotional. That's an image that I found when I googled talk to the poor. So experience or lack of, yes, that really influences our judgment of pain. And also our expectations as well. I think that's important is from a surgical point of view, if you're performing surgery, then we should think about how painful we expect that patient to be post-surgery. I think that's really important as well for when you learn new techniques. If you go on a course and learn a new technique as to how to repair a cruciate, for example, I think it's really important that you ask the questions, well, how painful should this patient be after surgery? Should they wake up really comfortable and quiet, or do they wake up howling? Hopefully they don't wake up howling, they shouldn't. But if your patient does wake up howling after the first time you perform this procedure, then that's something that we should have preempted and worked out before we did the surgery. So expectation is always something to think about as well. Acute pain assessment. So what do? There are 2 validated pain scales for both dogs and cats. There's the Glasgow pain scale and the Colorado State pain scale. And I know we had a walk around here yesterday and I saw both of these up on the wall in the ICU, so I know the guys at Massey are using these pain scales. And they're both really easy to use. If you haven't already got a copy, then just Google Glasgow Pain Scale or Colorado State, and you can just download them for free. The Glasgow Pain Scale one, they ask you to put your email address into the website and then they'll send you that as a PDF. And then you can either print loads of copies to use each time, or we actually laminate them and put them in the kennels at work. So really my approach to acute pain assessment is to prescribe analgesia, then write the patient up for pain scoring as well, and then instructions as to what to do if painful, so always formulate your plan. particularly if you're asking the nurses to do that, for nurses here, then it means that if you've decided that patient's painful, then you can go ahead and give the analgesic, or the nurse has something to do. They don't have to, or the vet's in a consult, or the vet's operating, I can't come and interrupt them. So write a plan up as to what to do if they're painful. So as I said, the Glasgow Acute Pain Scale is validated for use in dogs. There are 2 scores. It's either scored out of 20 or 24, depending on whether the dog is ambulatory or not. If it's non-ambulatory, then obviously you miss out the put lead on dog and lead out of kennel section. And what scores do you expect and when to provide analgesia? Well, in the validation study that they did at Glasgow, they came up with what they call intervention levels. So if the pain score's above this, then you should give analgesia. And those are 5 out of 24, and 5 out of 20, sorry, I always do that. 5 out of 20 or 6 out of 24. Now personally, I think those are a little bit high. One of the biggest variables that you see in the Glasgow Pain Scale is look at the dog, what is it doing in the kennel? And it's either quiet, screaming or whimpering, groaning or screaming, I think the last one says, I can't quite read it. So if you've got a really, really vocal dog, then people pain score them really high, but that dog may well have been really vocal before its surgery. So again, that's why I say it's really important. Ask in our case, it's the nurse that admitted the dog. What was the dog like when you put it in the kennel and closed the door? Was it going mad, or did it sit down quite happily? So that is really important. And when one of the nurses comes to me and says, well, I pain scored this dog at 8 out of 24, my first question is, what was the dog doing in the kennel? Was it howling? And actually, when you got the dog out, they come up to you and they wag their tail and they're absolutely fine. So I'm quite happy to take that kind of howling, vocalising behaviour out as contributing to the pain. So again, that's why it's really important, where you can, is to complete this section, put the lead on and lead the dog out. What do I expect? Where I work, we have a big orthopaedic caseload. I work with 4 orthopaedic surgeons, and we pain score all of the dogs after their surgeries. Very common surgery is cruciate surgery. So actually after a cruciate surgery where the dogs have had methadone in their pre-med, they may well have had a couple of doses of fentanyl during the surgery. They'll have had some type of local anaesthetic block, either a femoral sciatic, a lumbar plexus sciatic, or an epidural, which you'll learn how to do today, and a nonsteroidal. I would expect anything from 1 to 3 out of 24, maybe 4 out of 24. I'm not expecting those dogs to be really painful post-surgery. And it's like Brent said with the pancarpal arthrodesis example. If we analgese those patients really well at surgery, it's my feeling that we need to use less opioids in the post-op period. So, and that's something we're working towards actually demonstrating. But when I walk around the hospital, I'm pretty happy that all of these patients are actually very comfortable. And I think that's because we do such a good job perioperatively, and a lot of that is probably down to the local anaesthesia. Certainly find when the local anaesthetic technique doesn't work so well during surgery, we need to use more methadone. You'll catch me saying methadone. We use a lot of methadone in the UK. I gather you guys use a lot of morphine, completely interchangeable. So yeah, those dogs are receiving less opioid post-surgery. I'm sorry how this comes out. When you download the PDF, it's really hard to actually then put it on a PowerPoint. But this is the Colorado Cat Pain Scale. And we can see very much like the Glasgow Pain Scale that the emphasis is on the behavioural implications of that pain, so how the pain is affecting the animal's behaviour. And so we're examining the cat for postures that we know are associated with pain and behaviours we know are associated with pain. And we're also palpating the incision as well, and making an assessment of how tense we think that cat is. And it's got little pictorial examples down the side. Now the intervention level they set here is over 1, so any cat over 1 should be provided with analgesia and then reassessed to see if that analgesia is effective. These are some of the pictures that have been produced that we associate with pain in cats, which are pretty useful to use in conjunction with this pain scale, okay? I find those quite useful. So this is a great pain scale for cats. Since we introduced it probably a year ago, the nurses in practice absolutely love it, because before then there wasn't a validated pain scale for cats. We use what's called a visual analog scale, which is just a line from 0 to 100, and you mark on that line where you think that patient's pain is. So This is a lot more interactive. But you can see from both of these, the important factor is actually interacting with the patient, opening the kennel door, stroking the cat, assessing the wound. We're looking for hyperalgesia there. There is a pain scale. There are a couple of chronic pain scales for dogs. Nothing for the cat at the moment, but there are some in development. The one I quite like and have most experience of using is called the Canine Behavioural Pain Index, and that's the reference at the bottom there. I think the reference probably is in your notes as well, but if you Google Canine Behavioural Pain Index, again, you can download the pain scoring sheet. And this looks at two components. So again, it's assessing the behaviour, the animal's response to that pain. And it looks at pain severity and pain interference. And in the validation work for this paper, it's been validated for dogs with osteoarthritis and with cancer pain as well. So on day 0 and day 14, the owners were asked to complete this Canine Behavioural Pain Index. And then the dogs either received carprofen or a placebo. And as expected, carprofen did exactly what we know it should do. We saw a reduction in both pain severity and pain interference in both categories in that carprofen group, but not in the placebo group.
What is interference, pain interference? What do you mean by that?
How the pain interferes with the dog's daily activities. So things like greeting the owner when they come home from work, I want to say climbing the stairs, but I wouldn't encourage dogs in chronic pain. They shouldn't be climbing the stairs, really. But maybe going down the steps, get in the garden, something like that. This is an example of a dog that I saw in the chronic pain clinic that was treated with meloxicam and amantadine. This is a dog with spinal pain. And day 0, we used the Canine Behavioural Pain Index on this dog to assess the pain severity and the pain interference. And that gives you an overall score out of 100, and that's 48 out of 100. The last thing that the questionnaire asks the owners to do is assess their dog's quality of life. And at that stage, the owner felt the dog's quality of life was fair, which is quite sad. 2 weeks later, after this combination treatment, you can see the pain severity is quite markedly reduced, and the pain interference has reduced markedly as well. Quality of life, the owner scored as excellent, and the overall score was 4 out of 100. So this is a pain scale. We know it measures what we're asking it to measure. Okay. There has been some work on cats and chronic pain, and the 4 categories that they have focused on so far have been mobility, activity, grooming, and temperament. But as of yet, there are no formal pain scores. But when I'm talking to owners with cats in chronic pain, these are the areas that I sort of lean towards asking them questions about. So, what's the cat's mobility like? How does the cat cope with going through the cat flat? You know, some owners say, oh, the cat used to just pop through the cat flat, now he just really squeezes because he's really not happy. Activity, does he spend most of his day asleep? And that's the Napa cat that illustrates that. Grooming, is the coat greasy and scurfy now? And temperament, has there been a behavioural change, a temperament change? With talking to owners, as you go through a consult with these chronic pain cases, what's really useful is to identify behaviour that the owner says. And one of the quite useful cases I had, and you'll often pick them up during the first consult, but the owner won't attribute that to pain. And then it's later on, when you see them again, they say, oh, well, actually, the dog wasn't doing that before, now she's doing it. This was a dog with hip pain. It was a collie. She was about 8 when I saw her. And we started her with acupuncture, and she responded really well to the acupuncture. By about the 4th session, the owner said, you know, I know she's really much better now because she puts her flag up. And by that, she meant she puts her tail in the air. And that's a behaviour that the dog has stopped doing, and the owner hadn't appreciated that. And it's just one of those little behaviours that, with pain treatment, the dog suddenly starts doing these normal behaviours that it used to do. So if you can focus on anything in that first or second consult that the owner says the dog used to do, then those are quite useful behaviours to then gauge the efficacy of your pain management. So let's move on to looking at some concepts in analgesia. And I'm sure you're all familiar with the concept of multimodal analgesia, which is the use of different classes of drugs acting via different mechanisms to achieve analgesia. And really, when we're thinking about pain management in any patient, we're trying to target as many of these systems as possible to get a complete coverage of the pain pathway. The most common drugs we use, the most common 3 categories of drugs that we should always have at the forefront of our minds, whether we're dealing with acute pain or chronic pain, are the local anaesthetics, the opioids and the non-steroidals. Now obviously our focus today is going to be on the local anaesthetic part of this. I'm sure you've heard the term preemptive analgesia, which basically means providing analgesia before the onset of the noxious stimulus. And we're all very familiar with that, which is why we include analgesics in our pre-med. They're the main component of our pre-med. There's this new term, preventive analgesia, and that definition is an anti-nociceptive treatment that prevents establishment of altered central processing of afferent input from injuries. Now, where preventive analgesia is taking preemptive forward is looking at the whole pre, intra, perioperative, post-operative period and ensuring we provide analgesia for as long as that patient is painful for, okay? So if we think, how long, that's where the expectation, like I talked about earlier, comes in. How long do we think that patient should be painful for? How long after the cruciate surgery or the exploratory coleotomy do we expect? How long do we think we should be providing analgesia for? So just think a little bit about that. It's a real focus of current research at the moment as to the benefits of preemptive, intraoperative and post-operative analgesia. So it's a little bit too early to draw any conclusions, but the evidence is fairly well established for preemptive analgesia, certainly in dogs and cats. One thing to think about is that analgesia should be effective. So if we're giving preemptive analgesia, we need to make sure we're using drugs that have an onset before we're going to inflict pain on that patient. So one of the things to bear in mind will be buprenorphine. It's slow to associate with the receptor. It can take 30 to 45 minutes before buprenorphine starts working. We can do better. We can use morphine or methadone that has an onset of 5 minutes. And particularly with the non-steroidals as well, I should think a lot of the time, if you were to anaesthetize a cat, give it a non-steroidal, then spay it, chances are, by the time you finished your spay, the non-steroidal's not reached peak plasma levels yet. So that varies between non-steroidals, but I'm sure a lot of you guys can spay a cat in about 10 minutes, so, which I certainly couldn't because it's been a long time. So what's the evidence for preemptive analgesia? There are some nice studies. There are 3 studies we'll look at that all came out of Bristol in the UK, and Bristol's a hotbed of pain research and always has been. They looked at carprofen either before, after spay, or providing no analgesia at all to these patients. So they anaesthetised, I think it was acepromazine, thio, and it was back in the days, so I think they used halothane. So that combination we said where you don't provide any analgesia at all. And they looked at pain scores and mechanical threshold tests in these patients. And mechanical threshold tests are another way of quantifying pain. You use a device that's applied to the painful area, or say 2 centimetres away from the wound. And then when the animal reacts to that painful stimulus, the device gives a readout of force. And they documented in the patients that had carprofen pre-surgery, the pain scores were lower in that group. Very similar with pethidine, they use exactly the same study protocol. So we've got a non-steroidal and an opioid, and in both cases they were able to document preemptive analgesia in dogs with non-steroidals and opioids. What they noted here with the pethidine group is that the pethidine prevented development of allodynia, and allodynia is a painful response to a non-noxious stimulus. So probably the best example that we have of allodynia is if you have a bit of sunburn on your shoulders and you step in the shower. Normally the water on the back of your shoulder doesn't hurt, does it? But when you've got sunburn, that's unpleasant. So that's a really good example of allodynia. Now, allodynia and hyperalgesia. So hyperalgesia is an augmented response to a painful stimulus. Both of those are characteristics of central sensitization. And when we talk about sensitization, we split sensitization into peripheral and central sensitization. Now we know that peripheral sensitization is due to the action of inflammatory mediators. Our main inflammatory mediator that we're used to talking about and treating with our nonsteroidals are the prostaglandins. But there are a whole load of other inflammatory mediators such as bradykinin, substance P, calcitonin G-related peptides. I could go on. Basically, each individual substance starts a cascade of further inflammatory mediators. So that's what we're talking about when we talk about the inflammatory soup around the nociceptor. When peripheral sensitization is left unchecked and untreated, then we can get development of further pain input through recruitment of silent nociceptors. So these are nociceptors that are in all of us. They're not doing anything until a really, really painful stimulus comes along. So you can see that's really part of the fight or flight process, allowing our body to learn how to deal with that painful stimulus. Central sensitization is looking a little bit more further up the pathway into the spinal cord. So this is where we have a dynamic change in the dorsal horn excitability. And either that can mean upregulation or downregulation. And we'll look at some of the receptors responsible for that in a second. We know pain processing is altered. I've already said the whole system is not static, it's a dynamic system. And that's where the term plasticity comes from. Does good analgesia prevent central sensitization? That's quite an optimistic statement, but in the meantime, we should aim to provide the very best analgesia possible to prevent the development of either peripheral or central sensitization. And we have a lot of methods by which we can do that, which you're going to learn about today. We can examine our patients for allodynia and hyperalgesia and decide whether they have central sensitization. We've already talked about the definitions. You can examine for allodynia just rubbing a biro down the painful area. This was a dog with a brachial plexus tumour, and when you stroked a biro down the dog's over its shoulder and down the antebrachium, the dog reacted to that. So that's a non-painful stimulus, and the dog finds that painful. So this is a really good example of allodynia. And a brachial plexus tumour where you've got nociceptors firing continuously, that's probably a really good example where central sensitization can be allowed to occur. We can detect for hyperalgesia. The easiest way we do it in the clinic would be just to palpate around the wound. And when we're talking about hyperalgesia around the wound, that's primary hyperalgesia. If you've got a patient that's very painful, they're going to develop secondary hyperalgesia, which is hyperalgesia distant to the site of the wound. So you saw when Brent was examining the dogs on the video, you're examining somewhere else. With the PCA dog, he's examining the hind paw first of all to see how the dog reacted. That dog didn't react at all to having its site distant to the wound palpated, so it didn't have secondary hyperalgesia. The little Papillon, that dog definitely had primary hyperalgesia because it reacted to the palpation of its wound. How do we treat or prevent sensitization? As I said, we're fairly familiar at treating peripheral sensitization. We do it all the time in our OA cases, and every day when we analgese our patients for surgery, we're preventing peripheral sensitization. And the main class of drugs is the nonsteroidals. Opioids, there's some good work that shows that opioid receptors are upregulated in joints in particular. So far, that work's yet to translate into an incredibly convincing effect about using intra-articular opioids, such as intra-articular morphine. But there is a little bit of evidence emerging. And we think perhaps if you put morphine in a joint, you can probably expect up to 24 hours of analgesia from that. There's some very good work in horses, but the dog work is not as convincing yet. And local anaesthetics will look at using lidocaine as a CRI as well. So we're going to talk a little bit about the nociceptors now. So nociceptors, this is the definition of a nociceptor, a high threshold sensory receptor which encodes and transduces noxious stimuli. And they respond to a variety of stimuli, so thermal, mechanical, pressure and chemicals. So chemicals would be all of our inflammatory mediators. Mechanical and pressure, we can have those various stimuli during surgery. And when pain researchers are targeting new drugs, what they're looking at is applying such stimuli to the nociceptors and looking how one drug can respond right across the scale, whether it can control thermal, mechanical and pressure pain. Nonsteroidals really should always constitute the first line of defence. We know they're really good at decreasing inflammatory mediators. I personally don't think, as far as home analgesic options go and oral drugs for using in pain management, there are no other drugs that provide analgesia like the nonsteroidals, so don't forget that. That's why I say they're the #1 drug, because they are so effective. They have a role in preemptive multimodal analgesia. They're veterinary licensed, that's important. Veterinary license is really important because of the body of evidence that we have about the side effects these drugs produce. A lot of the other drugs, I'm sure you're all familiar with using things like Tramadol. We don't have a massive body of evidence for Tramadol. Nobody's gone and spent hundreds of thousands of dollars licensing Tramadol in dogs, which means nobody's actually done the research. We have population studies for nonsteroidals, and we know you could all list the side effects that you would expect from a nonsteroidal, whereas if I asked you to list the side effects you expect from Tramadol, very, very variable. Pretty much nonsteroidals work. If you give a dog a nonsteroidal, it works. If you give a dog Tramadol, might work, might not. So that's really where we're up to with nonsteroidals versus other drugs. We'll look a bit about the central effects of nonsteroidals as well. We know that in very painful and chronically painful cases, phospholipase is active in the spinal cord, and that causes centrally mediated hyperalgesia. So not only have you got peripheral hyperalgesia, you've also got the spinal cord contributing as well, which is a pretty bad situation to be in. And that decreases the production of arachidonic acid, which we know is at the top of our arachidonic acid cascade, contributing to the production of prostaglandins and prostacyclins. We should always think about when to avoid nonsteroidals. So my rationale for using nonsteroidals is any animal in pain should receive a nonsteroidal unless a clear contraindication exists, okay? So hypoproteinemia, something like a septic abdomen, if they've got an albumin of 15, then we need to be thinking really carefully about A, when to give the drug, and B, the dose of drug we give. Trauma, nonsteroidals are indicated in every trauma case at some point. Not when the traumatized cat comes out from under the car tire and hits the consult table, that is not the time to give that cat a nonsteroidal. They need to be stabilized, and as soon as you're happy that these animals are stabilized, they should receive a nonsteroidal. So the take-home message is, yes, these patients really benefit from nonsteroidals. And there are other things we can do to manage these traumatized patients in the meantime until we're happy to give them nonsteroidals. They're often not the happiest cats in the world for 12 or 24 hours while we stabilise them if we're using something like buprenorphine. When you then get a nonsteroidal into those patients, they really, really improve. So don't forget nonsteroidals in trauma. Concurrent steroid use, we know in man that steroid and nonsteroidal use doubles the risk of gastric ulceration, so let's not do that. Vomiting and diarrhoea, we all know those contraindications. Dehydration, let's rehydrate them first of all. Concurrent ACE inhibitor is always, it's on this slide because it's a question I always get asked. And the main reason is because both drugs are highly protein bound, and so they're competing for albumin to transport them around the body. And we don't really know who wins, who binds to the albumin, who ends up being the free active portion of drug. That's the main contraindications. We know ACE inhibitors, they do reduce your blood pressure, but we probably only expect them to reduce the blood pressure by about 10 millimetres of mercury, so we don't expect ACE inhibitors to completely crash your pressure. But I would be very careful about using ACE inhibitors perioperatively. So the current recommendation in people is that you stop ACE inhibitors 24 hours before surgery, which is my practice. And there are studies, I think there's a study in the dog looking at differences, whether they continue with ACE inhibitors perioperatively or whether they stopped them. Blood pressure was much easier to control in the dogs where they didn't have the ACE inhibitor on board. So I would stop an ACE inhibitor 24 hours before surgery. If you give an ACE inhibitor, anaesthetise the patient and give a nonsteroidal, then you could be running into problems with blood pressure then. I've put previous reaction there, and I think it's important to define what previous reaction means, and that means questioning the owner. So when they say, oh, my dog reacted to X, well, what do they mean by reacted to? If the owner says, oh, my dog was really stoned on this nonsteroidal, I think, really? We don't really expect dogs to be completely stoned on a nonsteroidal. So, or, oh, my last dog had vomiting with this drug, so I don't want to give it to my current dog. That's always a really difficult one to deal with. I do find, I'm sure you find as well, if a dog doesn't respond very well to one nonsteroidal, then switching nonsteroidals and trying another nonsteroidal can make a difference in those patients. So we don't know why. Paracetamol, a drug that is being used more and more recently, I think. Okay, we used paracetamol years ago before there were more nonsteroidals around, but it seems to be coming back to the forefront now, and I do think it's a good analgesic in some cases. Obviously this is just for dogs, not in cats. Cats can't metabolise it. And we're looking at a dose of 10 to 15 mg per kg twice or 3 times a day, that's a common dose that you'll find in formularies. We're not really sure exactly how paracetamol works, but we know it works. There are lots of studies out there, and if you look at one study, they say, oh, yeah, this is how paracetamol works. And if you look at another study, it's, no, this is how it works. When I talk to human anaesthesia colleagues, they say, well, yeah, we don't really know how it works, but we know it works, so we use it. So it is a useful drug. You can get an IV preparation as well, and we do use this in patients perioperatively where we can't give them a nonsteroidal if they're receiving steroids. That's a really good example. And again, I use 10 mg per kg 3 times a day in those patients. It is a really big volume because of the concentration of the drug. I don't know if that's the same preparation here in New Zealand though. Talking a little bit, staying with transduction, I said local anaesthetics can affect our transduction as well as our transmission. And the main example of this is lidocaine as a continuous or constant rate infusion. And we know lidocaine is really good at blocking neuronal function in neurons. Its action is peripheral as well as spinal when we use it as a CRI. The kind of rates that are recommended in dogs are a loading dose of 2 mg per kg and then a CRI of 30 to 100 micrograms per kilo per minute. I think probably most people are more familiar with lidocaine as a CRI in combination with morphine and ketamine as well. But I will use this with methadone or morphine. You dose the opioid every 3 to 4 hours or according to patient need and run this concurrently. So I would always use an opioid with a lidocaine infusion.
So is it kids as well?
Cats, if a cat's conscious, you can use much lower rates, but it's not recommended to use in anaesthetised cats. You know, cats don't respond very well to lidocaine because of the metabolites. Their liver's not so good at metabolising lidocaine. So if you look at the dose of lidocaine for converting a VTAC, it would be 2 mg per kg in a dog and about 0.5 mg per kg in a cat. So the rates are a lot lower in cats. I don't use lidocaine in anaesthetised cats, but I would use it in a conscious cat because you can monitor for signs of toxicity. Anything septic, but with the caution of hypoproteinemia. So lidocaine is very highly protein bound, so we do need some proteins to carry it around the body. So you can adjust your dose rate based on how hypoproteinemic the dog is. If their albumin is low, sort of 21, 24, I'd probably just start at the lower end. If the albumin is low, like 15, then I probably wouldn't use lidocaine in those patients. Really, our first-line analgesics as far as surgical pain goes are always the opioids, okay? So as I said before, morphine, methadone, very interchangeable. This is the dose range that I tend to use for these drugs, 0.1 to 0.5 mg per kg. The nice thing about both of them is if you use them IV, you have an onset within about 5 minutes, IM 5 to 10 minutes. So we're talking about really rapid onset drugs here. That means that we can titrate them. So you could, if you were concerned about your trauma patient, you could give 0.1 mg per kg of morphine to that dog or cat. If you don't think it's enough, just top it up, give more until you achieve analgesia that you're comfortable with. I'd be cautious going any higher than 0.5 mg per kg thinking, oh hang on, this patient's painful, I'm good. Well, I gave it 2 mg per kg and it was still painful. If you get to 0.5 mg per kg, that's when you need to be thinking multimodal and doing something else, okay? Fentanyl, we tend to use a lot of fentanyl perioperatively, so as a constant rate infusion as well. Anything from surgery from 5 to 10 to 20 mics per kilo per hour. Post-op, that's when you get the lower 1 to 5 micrograms per kilo per hour. So fentanyl is a very short-acting drug, so it's best suited for use as a constant rate infusion. It's not very useful otherwise, apart from interruptive rescue analgesia, which we'll deal with later. And I'm sure you're all familiar with using fentanyl patches in dogs and cats as well. Buprenorphine. This is really the only dose of buprenorphine that I ever use. Sometimes, if I've got a cat, those yellow cats with triaditis, where I think they're uncomfortable but their liver's completely knackered, I will use a lower dose of buprenorphine in those cases, because sometimes you give them the 20 mic per kilo dose and they're completely whacked on that. So those are about the only cases where I change my dose with buprenorphine. And it's incredibly versatile as well. IM, IV, cats, oral transmucosal works as well as IV, but only with that dose. If you use a lower dose, OTM doesn't work so well in cats. It is a partial mu agonist, which means it binds to the receptor, but from a pharmacologist point of view, it can't activate the receptor to the same degree as morphine and methadone. Now, for years, that's something we've all been taught. I'm sure you were all taught that with pharmacology. And when I go back and look at that, that's exactly what the pharmacology texts are still telling me. And we haven't been able to translate that into clinical research until recently. The main reason being, our human colleagues don't use a lot of buprenorphine. They just use morphine or fentanyl. They don't use buprenorphine, so there's never any drive to research that drug. So buprenorphine is kind of an underused drug in human fields, unless you're a heroin addict. There's some work published this year looking at using methadone versus buprenorphine in orthopedic cases in dogs, and they were able to document a positive benefit of the methadone versus buprenorphine. So that's the first inkling that we've got that methadone is in fact a better analgesia than buprenorphine. I mean, a lot of us have thought that clinically for years, but having said that, if you're talking about cats, there's some work that suggests that cats respond better to buprenorphine than they do to morphine. So really for me, the take-home message there is if you administer an opioid to a patient and it doesn't provide good analgesia, let's say with your cat, you get to 0.5 mg per kg of morphine and the cat's not really very comfortable, then the next thing to do is to switch opioids. So you can switch between opioids without too much trouble. And probably our most common situation is seeing cats that come in, they've had an RTA, they've been to the primary vet, they've had some buprenorphine, they come to us, they're still painful, I'll just barrel on ahead and give them methadone. I don't care when the buprenorphine was given. If it was given 2 hours ago, it's fine to give methadone on top of that. So you do see analgesia, those patients do seem more comfortable. You don't have to worry about the buprenorphine sitting there binding to the receptor and the methadone can't get in anywhere. The school of thought suggests there are tons of opioid receptors, so there is enough room for everybody. Butorphanol, excellent sedative drug. That is the licensed analgesic dose in the UK. I haven't checked what the licensed analgesic dose is here. I'm sure Stephen will be able to tell me. It's probably exactly the same. IM, IV, good sedation, short duration of analgesia, they say an hour to 90 minutes. Similar with pethidine, an hour to 90 minutes. Pethidine, a bit of a pain because we can't give it IV because it causes histamine release. So whilst pethidine is a full mu agonist and provides good analgesia, not as versatile as methadone, morphine or buprenorphine. So descending modulation is moving a little bit further up the pain pathway, looking at the dorsal horn of the spinal cord here and the contribution of the higher centres. So we know this isn't just a one-way system. Our body has inherent mechanisms of dealing with analgesia and damping down incoming noxious stimuli. And we know the brainstem can facilitate or suppress activity in the dorsal horn. And it's this area of the brainstem called the rostroventral medulla that's really important for this. And we know when the RVM is activated, hyperalgesia is very closely linked to that activation. This is a very interesting paper on the subject. The whole system is mediated by serotonin and noradrenaline, and you'll be familiar with drugs like the alpha-2s and Tramadol have these mechanisms. The whole system is designed to maintain a dampener, so it just controls the input into the CNS. And you can see where I said before, the way we respond to pain is based on our previous experiences. There's a component of descending modulation where that's important as well. So who wins? Do we see facilitation or do we see inhibition? We're not quite sure. What we do know is that early on in inflammation, an inhibitory effect predominates, but we don't yet know what happens in neuropathic pain. You can imagine that the facilitation is activated in neuropathic pain, and that's got to be, when we're talking about future drug targets, this system is really a target for future drug use. So, Tramadol, the alpha-2, this is where alpha-2s provide their analgesia. The sedation and analgesia associated with alpha-2s comes from the locus ceruleus. And we know opioids are also able to activate descending inhibition. So there are various places that opioids work. For this system, it's the overall balance that's actually key. And we see severe persistent pain being enhanced when facilitation dominates over inhibition. Same slide. Tramadol. I think we're all using Tramadol. We know acts on mu opioid receptors. In people, not everyone can metabolize Tramadol to provide the component that produces the opioid action. And I think that similar is true in dogs. What they say in people, though, is if you're a non-Tramadol metabolizer and you don't get the opioid effect, then the analgesia that you get is probably from the noradrenaline serotonin system. But there are people that don't respond at all to Tramadol, and that's my experience in dogs. I don't know what you guys think. If you prescribe Tramadol, does it work every single time? I don't think so. This is where it's really important to go back and ask the owners, speak to the owners, and say, right, I'm going to prescribe this drug. You've got to tell me whether it's going to work in your dog. I don't want to see you know, when you pop your head out the consult and the owners at the desk say 6 months later just getting more and more drug, getting a repeat prescription, you don't actually know how they're going. It's really important to keep up with these owners and say, is that drug actually working for your dog? Because if it's not, then we need to look for something else. That's the quite a commonly used dose in dogs for Tramadol. I tend to use up to 10 mg per kg, but really Tramadol in my hands, they get sedated, they get panty and they get anorexic, so I'm not really a massive fan of Tramadol. I think there are other drugs that we can use, and we don't really know how well it works in cats. Somebody's done some thermal threshold studies in cats. Typical of a cat study, if you give 10 cats the same dose of drugs, they all deal with that drug very differently and respond very differently. So cats are just like that. There is a little inkling of evidence for Tramadol that came out of this paper looking at a novel drug, a TRPV1 antagonist. So TRPV1 are receptors on the nociceptor. So this is, you can see where analgesic research has moved on to actually looking at targets. So this is a very valid drug target, and this company have developed an antagonist to this receptor, and it was compared against the gold standard being carprofen. We know carprofen, you give a dog carprofen, it does what it says on the tin. I don't know why they threw Tramadol in there. I'm not quite sure what the rationale for having 4 arms in this study was, because they just wanted to compare this drug against a placebo and against something that works. Don't know why the Tramadol ends up in there, but that's how we came to have some evidence about Tramadol. These were dogs with hip osteoarthritis, and they used, for outcome measures, they used the Canine Behavioural Pain Index, they used activity monitors, so accelerometers attached to the dog's collars, gait analysis, and the administration of rescue medication in the study. And whilst they were able to show that carprofen did exactly what it should do, for some of these outcomes, they showed that there was a benefit to Tramadol. interesting, there was a benefit to the test drug, but it just made the dogs quite sick. So not the kind of drug that you could release to the general population if it's going to make dogs vomit left, right and centre. In the placebo group, as you might expect, with an owner-based pain scoring system, some of the owners did think that their dogs improved on the placebo. So this is again something when you're dealing with talking to owners about pain management, just keep that in the back of your mind. Some owners just want their dog to improve. So that's why I think it's really important that we use drugs that we have the most evidence for and we know work. Because there are dogs that won't respond to Tramadol, but owners that do respond to their dog having Tramadol. So just be careful. We talked about central sensitization, and the NMDA receptor is a receptor in the dorsal horn of the spinal cord here that is mainly responsible, one of the key receptors responsible for central sensitization. And we know that this receptor is activated in cases of chronic pain, therefore it's a good target for therapy. So under normal circumstances, a stimulus from the periphery goes up your primary afferent and it reaches this synapse here. Normally, it's transmitted through this receptor called the AMPA receptor. Under circumstances of either intense stimulation, so surgery, for example, would be a good example, very painful surgery, or prolonged stimulation, so an animal with chronic pain, neuropathic pain, for example. There's a lot of activation going on here, and this neuron becomes hyperpolarized. Now, this NMDA receptor is normally inactive because of this plug of magnesium that sits in the channel of the receptor. Now, if we've got hyperpolarization here, that magnesium gets kicked out and it opens that receptor up for activation. So the receptor becomes activated and it's just a pain motorway going up to the thalamus and cortex. So this is a great receptor to target, not only in acute pain but chronic pain as well. We know that descending facilitation that we talked about before is NMDA dependent, and that does occur quite early on in inflammation. So we should always be thinking about targeting the NMDA receptor or using our local anaesthetics so we don't see this wind up that we hear about. So we can use ketamine for this. This is that third study that I talked about from Bristol. Very similar study to the previous two, looking at either 2.5 mg per kg of ketamine IM either before surgery, at extubation, or no ketamine at all. And these were bitch spays. The measures were interventional analgesia, so they use a rescue analgesic of carprofen, mechanical threshold testing and pain scores. And they were able to document there was less interventional analgesia required in the pre-op group and less wound hyperalgesia in that group as well. This is a really easy technique to use. I don't often use as much as 2.5 mg per kg, but I do use 1 mg per kg quite commonly, intraoperatively. Either when the dog reaches the operating theatre, the dog will have its bolus of ketamine, or CAT, bolus of ketamine before the surgery starts, or if I've done a nerve block and I want to see how my nerve block goes, if the nerve block doesn't work, this is a great rescue analgesic to do. So 1 mg per kg IM if the animal reacts to surgery, or you can use 0.5 mg per kg diluted slowly IV. You should always use it with opioid analgesia, and that was one of the statements in the discussion of this paper. They said you should always use a background opioid.
What if you're using ketamine as a reduction agent?
You should have some effect. Ketamine normally as an analgesic probably lasts about 20 minutes if you do this. So when I say if the animal reacts to surgery, you give the ketamine and then it tends to settle them down for the rest of the surgery, unless you have another very painful period of surgery, say an hour later, and you might need to give another bit of ketamine. You should see an analgesic effect quite early on after your ketamine diazepam induction. I guess it depends how long between induction and surgical and starting the surgery is. So I suppose if you took the example of a cat spay that you'd use a triple combination on, we use ketamine in the triple combo, you don't really see the cats reacting when you start the ovarian hysterectomy, do you? So.
How long would it take before you'd see the effect, like if you gave it?
Really quick. Yeah, it's quick. So if you know those cases where you start and the dog just starts panting, if they then have ketamine 1 mg per kg or even 2 mg per kg IM, a minute, a couple of minutes, and they'll settle down and you can carry on. So it's a lot quicker. The other option, of course, is just turning up the isoflurane, and that takes just probably longer. Once the dog's panting, they're doing this silly little breath, so they're not going deeper. And actually, this is providing analgesia. Just turning up the ISO, it's just crashing your blood pressure and not doing anything to analgese the patient. So this would be my preferred option, rather than turning the vaporizer up, giving a rescue analgesic like this. Having said that, I have tried it on bitch space. I personally find bitch space one of the most difficult things to anaesthetise and keep at a really nice stable plane of anaesthesia. That's where I like using alpha-2s in them. But so if you go back and you try this on bitch space, some of them they just don't want to know. You pull on the ovary and they'll be jumping off the table still. So personally, I find that that's a massive stimulus. Not personally, but it is a massive stimulus. Obviously, having your ovary tugged on. And there's been a lot of work looking at, where should we put local anaesthetic? Should we splash it on the ovary beforehand? Should we put it in the pedicle? There are no studies that conclusively show putting local anaesthetic around an ovary makes a big deal of difference. So it's one of those pain models that is quite a tough, it's obviously a really big stimulus there that's quite tough to get over, yes.
We use morphine, ketamine, Donadol for our anaesthetics for cats,
Yeah.
But one of our nurses recently went to a similar course to this, and the comment was made that morphine's quite nasty in cats as far as toxicity and stuff.
There was, years ago, people were using really big doses, like 1 mg per kg of morphine in cats, and reported these cats were manic with morphine, and so morphine went out of vogue with cats because of, it was basically people using high doses. Cats can't glucuronidate drugs, which is why paracetamol kills them. They can glucuronidate morphine to a degree, but in some cats, they can't do it as well as other cats. So it's like I say, if you gave 10 cats morphine, they'd all respond quite differently to it. Methadone is potentially, as far as cats go, it's demethylated, it's not glucuronidated. So from a pharmacology point of view, it's probably a more reliable drug in cats, as is buprenorphine. They don't undergo glucuronidation. I think the important thing there is if you're using morphine in cats, look and see if it's working, or if you're happy that it's working, then it's working. If it's not, switch to buprenorphine. So, yeah, that would be. But if you're using it and you're happy it's working, then fine.
We use a similar formulation, but we actually use butorphanol.
Yeah.
With ketamine,
Yeah.
Would using buprenorphine instead give us a better pain?
Yeah, in theory, yeah. Sorry, that was using, instead of using medetomidine, ketamine and butorphanol, could you get better improved analgesia using buprenorphine instead of butorphanol? So you would get a longer duration of action of analgesia with your buprenorphine, yes. Yeah. Or you could replace it like the lady does, you could use morphine instead. So you can replace the opioid with anything in that combination, yeah.
I'll often use butorphanol with the buprenorphine because the buprenorphine sedative effects are.
In cats?
Yeah.
Yeah.
Just because they're so much less reliable than butorphanol.
Yeah, butorphanol is a better sedative than buprenorphine is. We already said about buprenorphine have a slower onset of action. So there was this school of thought, if I give the butorphanol, you get the rapid effects of the butorphanol and then the buprenorphine kicks in later. So somebody actually looked at this in the States because it was quite popular in the States. So they had a butorphanol, a buprenorphine and a combination group. And compared to the buprenorphine, they weren't able to demonstrate a benefit to the butorphanol-buprenorphine combination. So, but that was, I can't actually remember the details of the study. I've probably got it on my computer. I can't remember the exact specific outcomes they looked at and the sample sizes. So those two things will have an effect on the result. But if you're using it and you're finding a benefit, then carry on using it. Yeah. So we talked about using ketamine as just a one-off shot, but some of you will have heard about using concentrated infusions of ketamine. Some of you will be using concentrated infusions. We know in people, ketamine CRI is opioid sparing and it reduces post-op nausea and vomiting in people. We don't really see this in dogs. We don't think. I think some of our patients might look a bit nauseous. And this study from France looked at using ketamine CRI in dogs undergoing a mammary strip. And they used 2 different doses, and in the optimal dose, they showed that in the dogs that had ketamine CRI, the food intake was improved in those dogs post-op. So that could reflect less nausea, potentially. That's probably one of the first studies looking at food intake in hospitalised dogs, and that's something I'm quite interested in, is A, how much food do dogs actually eat of their normal ration in hospital full stop, and can we change that depending on our analgesia? So I think looking at food intake probably is quite a good outcome measure in studies. The rates I use for ketamine in dogs would be 10 micrograms per kilo per minute, and then 2 mics per kilo per minute in recovery. You can use this for 24 hours in recovery, that's fine. Loading dose of either half a mg per kg IV or 1 mg per kg IM. And in this study looking at limb amputations, it was a small study, and they did comment they didn't have enough numbers to show statistical power, but they did document lower pain scores at the 12 and the 18-hour time point in the dogs that had a ketamine CRI added to their morphine, and improved activity scores on day 3 in those patients. So I would always say use it as an adjunct, so always use it with opioids. I put phantom limb pain on there. We don't know yet whether either local techniques or using ketamine as a CRI can prevent phantom limb pain, and that's coming from human research. So something people talk about all the time, oh, if we do this, can we prevent phantom limb? Even the huge numbers of cases that we have in the human population hasn't given us an answer yet, but I think it's a very good, that doesn't mean that we shouldn't try. So where I use ketamine would be spinal cases, things like total ear canal ablation, amputations, septic abdomen, for example, or any type of orthopedic surgery. Logistics-wise, it's a really easy one to do. You just use your ketamine. Is your ketamine 100 mg per mil here? Pretty sure it is, yeah. So you just put a mil of ketamine in a 100 ml bag of saline, and that makes it up to 1 mg per mil. And then the actual dose rate works out. If it's a 6 kilo dog, then it gets 6 mils an hour perioperatively, and then you cut it down in recovery. So that works really nicely. Looking a little bit more about some of the chronic pain drugs that people are using, we have a reasonable amount of experience of using gabapentin, but there's no real rock solid evidence at the moment, other than, yeah, well, I think it works. For gabapentin, it binds to voltage-gated calcium channels. That may be one of its mechanisms of analgesia. It's one of those drugs that we know works in people. We don't exactly know how it works, so quite common to some of these chronic pain drugs that we have already in existence. We know that voltage-gated calcium channels, they're upregulated in central sensitization, so they seem like a sensible target. It has been documented as being used in trauma cats where the cats aren't in that stage where we're happy to give a nonsteroidal yet, so in combination with opioids, and that will be a dose of 10 mg per kg twice or 3 times a day. But that was, that's documentation, that wasn't a formal large study. But I use it in those cases and I think it makes a difference. So, like you'll see with a lot of the chronic pain drugs that we're dealing with, a lot of it, we'd like it to be evidence-based, but it's not yet evidence-based. We know that from studies in people that gabapentin, yes, it's mostly used for neuropathic pain, but it's not just a drug only for neuropathic pain. There are several studies, these are some examples of its use in acute pain management. So these were studies where the human participants would receive a dose of gabapentin orally before their surgery, and that was the only gabapentin they got. It was just single dose, and they were able to demonstrate lower pain scores, decreased opioid consumption, improved respiratory function. These are some of the examples of the positive benefits of gabapentin perioperatively. So there may be a role in the future for gabapentin as a perioperative analgesic in veterinary patients. It's not something I'm using yet. If I've got chronic pain patients, for example spinal patients that we see, they may well be on gabapentin already, then I will carry on the gabapentin perioperatively. I'm not worried about it interacting with any other drugs around the time of surgery. So we've already talked about ketamine, using it as a rescue analgesic, but there are a lot of other drugs that we can use as well. And I think this is really important when we're learning to do our local anaesthetic techniques, because you'll see one of the slides I put up later is, well, why didn't my local anaesthetic block work? Sometimes we can do the most perfect block in the world and it just doesn't work. I'm never quite sure why. Therefore, when that block doesn't work, we need some rescue options. So just as an example, you may have pre-medded with buprenorphine, you've used a nonsteroidal and you've done a local block, and then that animal reacts to surgery. And by reacting to surgery, what we would be looking at is your baseline heart rate, rest rate, blood pressure before the surgical stimulus. If that increases by any more than 20%, then that indicates nociception and the animal requires further analgesia. So I'd be looking at a bolus of fentanyl, either 1 to 2 micrograms per kilo IV. If you give 2 mics per kilo rapidly IV, you may well see some post-fentanyl apnea. That's not a problem. You have a breathing bag, you just squeeze the bag. It scares the hell out of the nurses the first time you do it though, so if you're going to do it, just warn the nurses, okay fine, if the dog does stop breathing, just give them a breath and they'll start breathing again within a minute. Ketamine, we've already talked about ketamine. If you push ketamine IV fast, then they will develop apnea for a little bit longer as well, especially when they're anaesthetised. So again, squeeze the bag or give it very slowly IV. The alpha-2s, if you've used an alpha-2 in your pre-med, or even if you haven't, if you use an ace-promazine morphine pre-med, you can still give an alpha-2 as a rescue analgesic. And we're talking about quite low doses here, so 1 to 5 micrograms per kilo of either dexmedetomidine or medetomidine, whichever alpha-2 you're using. That can be a really, really nice rescue. Don't forget though the effects that we see with the alpha-2, so you will see a bradycardia, so that's always something to warn the person monitoring the anaesthetic. Don't worry, yes, you see an alpha-2 bradycardia, but it's nothing to worry about. And we should always consider repeating our opioids, so has it been 3 or 4 hours since we gave that morphine? If the animal's reacting to surgery, let's just give some more opioid. Turning up the isoflurane is really not an option unless the patient was light to start with. So if you're looking at the patient's reflexes before the surgeon starts and they look light, by all means turn the isoflurane up. But if that dog was at a decent plane of anaesthesia before the surgical stimulus, then it needs analgesia rather than the vaporizer turning up anymore. I think to conclude this section, can we prevent chronic pain from happening with our local anaesthetic techniques? This is an area that our human colleagues are starting to look at, and there's a little bit of evidence but not a whole load. So we know, and one thing that's really important is absence of evidence isn't necessarily absence of effect. So the intention is that with our local anaesthetic techniques we prevent peripheral sensitization, central sensitization, we prevent chronic pain. There is some work emerging at the moment for the 2 conditions that have been studied have been thoracotomy and breast cancer surgery, and epidural anaesthesia or paravertebral block may prevent persistent chronic pain in 1 out of every 4 or 5 patients. So this was a meta-analysis, so a collection of lots and lots of studies looking at those two specific areas. What we haven't got is anyone looking at orthopaedic surgery, and probably veterinary-wise, a lot of our caseloads can be made up of orthopaedic surgery. If we're talking about surgeries where we think are very painful and there may be a potential to go on and develop chronic pain, nobody's actually looked yet at orthopaedic surgery as far as whether we can prevent chronic pain. So that is the hope. And that's really the aim of today, is doing the best we can to prevent pain wherever possible.